We've got some interesting talks, 4 different diseases, 4 new treatments. Why don't we bring my panel up now? And we have a distinguished panel here. For Late Breakers 2, I have Alan Ho, Szilárd Kiss, Dimitri Skandra, and Richard Rosen. If you can join me on the stage here, would be great. This is a very seasoned group here of clinician investigators who are going to help interrogate these speakers after they give their talk with me. But our first talk is going to be on Tinlarebant, LBS 008, for adolescents with Stargardt's disease, Quan, Nguyen. Thank you.
Good morning. On behalf of the Tinlarebant Stargardt disease group, it's our great pleasure to show you the result of our work. Our disclosures are listed in this slide. Patients affected with Stargardt disease harbor genetic mutation that interfere with normal vitamin A processing that then lead to the accumulation of societal byproducts of toxicity, vitamin A, bis-retinoid, that progress to cell death. Therefore, it is expected that reduction of vitamin A delivery to the eye can then reduce the pathology and preservation of the vision in Stargardt patients. Tinlarebant is a once-a-day oral tablet that's designed to bind to the serum retinol binding protein, RBB4, to slow or halt the accumulation of bis-retinoid. Therefore, early intervention is perhaps thought to be the best approach to potentially slow the disease progression in Stargardt and geographic atrophy. In Stargardt patients, the dysfunction of ABCR protein results in the accumulation of the R-transretinal, leading to formation of the retinal dimer lipid complex. These complexes are then accumulated in the cytotoxic bis-retinoid. Tinlarebant is a RBB4 antagonist. After it's bind to the RBB4, then the Tinlarebant RBB4 complex is liberated into circulation and eliminated to the kidney due to its small size. In our phase 2 clinical trial, 13 subjects of ages 12 to 18 diagnosed with Stargardt were enrolled. The subjects were treated with Tinlarebant 5 milligrams a day for over a 2-year period of time. Safety was certainly measured. In addition, evidence of bioactivity was assessed to DDAF, QDAF, OCT, and microperimetry, among others. The 5 milligram dose was chosen because it has been shown to be effective in reducing the RBB4 level by a mean approximately 80%. Severe biallelic ABCA4 mutation were found in the majority of the subjects in our trial. Yet, despite the severe mutant allele, many of the subjects did not develop atrophic lesion during the phase 2 study. During the 24-month study, transition from the QDAF to DAF lesion were examined. In 42% of the subjects, no incident DDAF lesion growth were observed. In nearly 60% of the subjects, incident DDAF lesion occurred only within the QDAF lesion, and there was no expansion of the QDAF size. Visual acuity was stabilized during the study. In a subgroup of 6 subjects, which showed a mean loss of 10 letters per year prior to their study enrollment, following the 24-month treatment, now reduced down to about 3 letters per year. The Ocular Imaging Research and Reading Center, which served the reading center for this study, had developed a mathematical classification of lesions based on the proximity of the gray value to that of optic disc, focused on specific regions that enhance the accuracy of localization and quantification. And this FAF analysis using this novel grading methodology was employed to show atrophic lesion within the macula. The growth atrophic macular lesion was stabilized from month 16 to 24, and the extent of the macular lesion involvement was less than 7%. During the 24 months, certainly adverse events were closely monitored. Xanthopsia, delayed adaptation, and night vision impairment were noticed, but they were graded very mild. Tinlarebant at 5 milligrams daily were well tolerated in adolescent Stargardt patients. No severe or moderate drug-related adverse event and no adverse event that required discontinuation of treatment was noted. So in summary, during this 24-month phase 2 clinical study, the 5 milligram Tinlarebant produced a mean of 80% reduction of plasma RBB4 retinal. Using the standard FAF imaging showed that over the 2-year period of time, 42% show no incident of atrophic DDAF lesion, and the QDAF lesion did not increase in size. Visual acuity was stabilized in subjects with significant visual loss prior to enrollment. And then using a newly developed lesion grading algorithm, the growth of this macular lesion was halted during the month 16 to 24. No systemic drug-related adverse event and no study withdrawal were noted in the study. We would like to extend our deepest appreciation to the many investigators, study site, and subject patients who have helped to make our study a great success. Given the very encouraging data, Tinlarebant has now been involved in the phase 3 study program, the Dragon study, which has finished its global enrollment. Many of the subjects have now passed year 1, and we are waiting for the year 2 outcome. In addition, Tinlarebant is now being involved in a global international phase 3 study in geographic atrophy, the Phoenix study, and we look forward to sharing with you the result in the future. Thank you for your attention.
Thank you. Thank you, Quan. The next speaker is going to be Roger Goldberg, talking to us on pooled visual function data of neurotrophic factor-producing Revakinagene Taroretcel in Mactel type 2. There's a tongue twister.
Easily said as NT501, I'm pleased to be presenting on behalf of the Mactel study investigators the pooled visual function data of the neurotrophic factor producing Revakinagene Taroretcel, or NT501, in patients with Mactel type 2. Here are my disclosures. Mactel, of course, is a progressive bilateral retinal neurodegenerative disease. It starts typically paracentrally, but ultimately leads to central vision loss and functional vision impairment. And it's associated with abnormalities in the Macular glia, RPE cells, and photoreceptors in the central retina, and characterized by, among other things, progressive loss of the ellipsoid zone, the photoreceptor layer, on spectral domain OCT. Ciliary neurotrophic factor, or CNTF, works through the JAK-STAT pathway and is a neuroprotectant. It activates a pro-survival pathway, and both in preclinical models and now in several studies in patients with macular telangiectasia type 2 has demonstrated its neuroprotective function. The CNTF gets released in a very clever design called encapsulated cell technology, where you have modified RPE cells that have been programmed to secrete CNTF, and they're housed inside a semi-permeable membrane that keeps the immune system at bay while allowing nutrients in to feed those cells, keep the RPE cells alive, and allows the diffusion of CNTF into the vitreous cavity where it's able to work. It's a one-time treatment with data to suggest that these cells are continuing to work 15 years after implantation. NT501 has been studied across 3 randomized sham-controlled clinical trials. A phase 2 study that had 99 eyes and 2 parallel phase 3 studies, cleverly called NTMT-03A and NTMT-03B. The studies were very similar, but I do want to highlight a couple differences. The phase 2 study allowed for larger lesions with an easy break area up to 4 square millimeters, while the phase 3 studies were capped at 2 square millimeters in maximum area of easy loss. In the phase 2 study, if a patient had 2 eligible eyes, both eyes were eligible to be enrolled, and 1 eye was randomized to sham and the other 2 treatment. Whereas in the phase 3 studies, only 1 eye of a single subject could be enrolled. Both used an anatomic endpoint looking at EZ area loss through 24 months. In the phase 2 study, it was the change in baseline. In the phase 3 studies, it was the rate of change from baseline in EZ area loss through 24 months. And importantly, all 3 of these studies had important functional endpoints around reading speed, aggregate retinal sensitivity as measured by microperimetry, and BCVA. And you'll see shortly that most of these patients, because Mactel tends to start paracentrally, had excellent vision at baseline as measured by BCVA. And so we really think of the BCVA data, as a safety parameter. Each study lasted for 24 months. So what's our rationale for pooling these 3 different clinical trials? Well, first of all, Mactel is a rare disease, so it's hard to gather enough patients to appropriately study it kind of en masse. And although our anatomic endpoints we can image down to kind of almost the individual cell layer, certainly down to a micron level, with high reproducibility. Our functional testing in many macular diseases we know has a high degree of test-retest variability. And so because these three studies enrolled a similar population with similar designs, by aggregating the data, we're able to increase the sample size and try to hone in on what the true effect is of NT501 in patients with MacTel. So again, we looked in this pooled population at not only the anatomic data, but the functional data in terms of monocular reading speed and aggregate retinal sensitivity, or microperimetry, as well as BCVA. Here's the baseline characteristics by participant. We see that the groups are well balanced across all studies and treatment arms. When we look by eye, not surprisingly, the phase 2 population tended to have larger lesions because they allowed larger lesions into the trial, with more patients having lesions greater than half square millimeter in EZ loss at baseline. Here's the aggregated data. In total, we see the phase 2 and phase 3, when we compare NT501 versus sham-treated eyes, to be quite similar across the two populations. So let's take a look at the pooled data. Here's the anatomic data, again, looking at EZ area over 2 years. We see some degree of variability in each of the three individual studies, but when we aggregate that data, we see 36% reduction in photoreceptor loss at 2 years. What about reading speed here? Again, a test with a high degree of test-retest variability. Not surprising, we see some differences across the three studies individually. And when we aggregate that data, we see a 68% reduction in reading speed loss at 2 years with NT501 in patients with MacTel. Microperimetry, similar story. Two of the studies showed about a 48% reduction in loss of aggregate retinal sensitivity. The phase 3B study showed a smaller reduction, but when we aggregate this across all three studies, we see about a 35% reduction in aggregate retinal sensitivity loss. BCVA, I mentioned earlier, patients tended to enter these studies across all the treatment arms with quite good BCVA, somewhere between 70 and 77 letters. And although there was a one-letter difference favoring NT501, not only is this not statistically significant, I don't think any of us would argue that one letter is clinically significant either, but it does suggest that there's a good safety profile here. And there's been talks earlier and another talk later today in the general session on the safety of NT501. So in conclusion, across 320 eyes in these three studies, we saw a great connection or correlation between the structural benefit and the functional benefit, both in terms of reading speed and retinal sensitivity loss. Thank you.
Well, let's open up the discussion now for a few minutes with our distinguished panel. Alan, why don't we start with you? What are your thoughts on Tinlarebant, the data you saw Quan present? Any comments? Yeah.
I think well, just to comment about both programs, I think the diseases are not so rare. Stargardt's and certainly MacTel we see in the clinic, and we've been telling patients for many years that we don't have anything. So I think specifically regarding the phototransduction cycle vitamin A modification, I do have patients that don't tolerate it well. So in Chapter 1 of a treatment where we're looking at morphologic endpoints in both these studies as primary endpoints, I think it's a reasonable start. I would rather be attacking the molecular issue itself than reducing vitamin A, which is required for rhodopsin, but congratulations to the author, and I like the way they're looking at evaluation of the atrophy in a different way.
Yeah, Dimitri, what do you think going forward with this drug, Tinlarebant? Let's talk about first. What do you think as far as study endpoints? Are you have concerns, or we're not really seeing a visual improvement, actually a decrease? It's reminding us of the GA.
I think we're going to a new era as we're attacking these diseases earlier, and I think it's a great move to the field that we're trying to find different biomarkers and ways to evaluate the lesions. before they attack the vision. But I think that we need to be also careful and validate these new kind of biomarkers and ways to quantify the lesions using natural history data, so that way we can apply them to clinical trials. So I think we need to get a good lesson from a fresh IRD that they look at natural history data sets and then use them in endpoints. I think that would be a great way moving forward, but we need to make sure that we know what we're measuring and how that's reliable.
Szilard, anything to add, or?
No, I mean, I think, perfect points. I think both these talks sort of highlight the non-traditional endpoints that are important to our patients that go beyond visual acuity. And I think that we do need to work with our regulatory agencies in addition to companies and as well as patient advocacy groups to make sure that we're looking beyond just visual acuity. So I like that in both these talks.
Yeah. Richard, let's switch gears a little bit and talk about NT501, if you would. And are you excited about this possibility for your patients? How are you going to integrate it in the clinic?
So it's very interesting. We haven't had anything for this group of patients. Right. So having some treatment to point to. Very interestingly, I've been discussing this with patients over a number of years, and there's a group of patients who are very symptomatic and want to do something, and there hasn't been anything available. And then there are another group of patients who say, well, it's slow, it doesn't seem to be affecting my lifestyle, I'm not ready for surgery. So I think that, they're very different take on how this, it's a very asymmetric disease too. It may be bilateral, but some patients have one eye that's very affected and the other eye, you can see it when you do OCT or you do autofluorescence, and basically the patient is asymptomatic. So I think it's going to come down to the patient. One thing about the technology, it's shown value in terms of preservation of anatomy previously when they were in the RP studies, but it didn't really show sustained functional endpoints. So it's exciting that it has shown some.
Alan, you have a comment?
Yeah,
burning comment?
Regarding the platform of encapsulated cell technology, engineering RPE cells to produce something, I think it's a fantastic platform. I think this is a good first shot on goal for an untreatable disease that has variable symptoms. I'm looking forward to December when they get evaluated by the FDA and we learn whether or not we can offer it. I think this platform has failed before in production of anti-VEGF for wet AMD, despite modifications of more tubes to increase surface area, et cetera. But I like the fact that it seems to be working for this group of patients. And I think we're going to be thinking about pharmacosurgical interventions for other diseases as well.
Dimitri, anything, last 25 seconds? Are you going to use this in your patient? What patient?
I have a lot of patients with MacTel, and I agree with Richard. There are some patients that are very motivated, and I'm very excited with the results that we see both functional outcomes, not only anatomical outcomes. So I think that and there's no safety signal, so I would.
I'd like to thank the two speakers. You can go out to the audience now. No questions for you. That's how clear your talks were. But let's move on to the third talk in this session. This is intravitreal FAS inhibitor, ONL-1204 for Macula-off retinal detachment. Durga Borkar is going to give this talk.
Well, thank you to the program committee for the opportunity to present on FAS inhibition with intravitreal ONL-1204 for the treatment of macula-off Rhegmatogenous retinal detachment. These are results from the phase 2 study. These are my financial disclosures. We know that many patients with macula-off Rhegmatogenous retinal detachment suffer from irreversible vision loss, even with successful surgical repair. Many studies have shown that time is vision when it comes to the duration of macula-off status. The Scottish Retinal Detachment Study, among others, showed that the extent of vision loss increases with the duration of macula-off status, especially if the macula is detached for greater than 8 days, as shown on the right. The FAS receptor sits on the surface of cells and is upregulated in a disease state. FAS is part of the TNF family of receptors and is a key regulator of cell death and inflammation. ONL-1204 is a 12-amino acid peptide that has been shown in multiple preclinical studies of retinal detachment to preserve photoreceptor health via FAS inhibition. This is one example of a preclinical study in a rodent model of retinal detachment via subretinal injection of hyaluronic acid. Tunnel stains for DNA breaks that occur during apoptosis. And in this study from the Zach's lab, we can see that the percentage of tunnel-positive outer nuclear layer cells is significantly higher in a detached control shown in the center compared to a detached eye treated with ONL-1204, suggesting that FAS inhibition can preserve photoreceptor cells during periods of retinal separation from the RPE. This was a phase 2 randomized sham-controlled single-mass study to assess the safety and efficacy of intravitreal ONL-1204 in patients with macula-off rhegmatogenous retinal detachment. In this study, 135 patients who had MAC-off RRD for between 24 hours to 14 days prior to presentation and treatment were randomized on a 1-to-1-to-1 basis to receive either 50 micrograms or 200 micrograms of ONL-1204 or sham. Patients receive this via single intravitreal injection at least 12 hours prior to and no more than 10 days before surgery. Surgery was standard of care pars plana vitrectomy with or without scleral buckle. The primary efficacy endpoint was contrast sensitivity as measured by the AST manifold contrast vision meter at week 24. A key secondary endpoint was BCVA at week 24. When looking at the data, the baseline characteristics were well balanced across the 3 treatment arms. The average duration of MAC-off status to presentation was approximately 5 days in all 3 groups. It is particularly notable, since this is a single mass study, that the duration of MAC-off status to surgery was about a day and a half longer in the ONL-1204 200 microgram arm compared to sham. And the duration of MAC-off status greater than 8 days occurred in about 50% of ONL-1204 200 microgram arm patients compared to the sham, which had only 25% of patients with a duration of MAC-off status greater than 8 days. Vitrectomy alone was the most common procedure performed, and gas tamponade was used in almost all patients. In terms of the efficacy in this phase 2 study, there was no statistically significant difference found across the treatment groups in contrast sensitivity. However, analysis of pre-specified subgroups demonstrated a trend towards neuroprotection in patients with greater than 8 days of macula-off status. Looking a little bit more at the primary outcome of contrast sensitivity, this was measured using the AST manifold contrast vision meter, which is a novel approach to quantifying vision that looks at both contrast and then also size or frequency. Some of the benefits of quantitative contrast sensitivity as a clinical endpoint include efficiency, good test-retest reliability, and sensitivity to early changes in visual function, as well as the ability to see differences after therapeutic intervention that may be more than visual acuity alone can detect. As an example of this, this is a study from the University of Michigan by Dr. Zachs and Dr. Thomas looking at contrast sensitivity after macula-off retinal detachment. And a key finding in this study was that even patients with relatively good vision after retinal detachment repair had significant contrast sensitivity dysfunction compared to fellow or control eyes. So the hope was that by using contrast sensitivity, there would be an increased ability to detect a treatment effect. ONL-1204 failed to meet the primary endpoint, and the trend lines were similar for the 2 ONL-1204 treatment arms and sham. Looking a little bit further at lens status and contrast sensitivity, we can see in the phakic subgroups at the bottom that there's a large amount of variability in contrast sensitivity in phakic patients, which is expected given that cataract, particularly post-vitrectomy, can contribute to contrast sensitivity. And this is important to consider for future clinical trials. Looking at BCVA, the change in mean visual outcome for patients with greater than 8 days of macular detachment was about 2 lines better in the ONL-1204 200 microgram arm compared to sham. And when looking at BCVA at week 24 in pseudophakic eyes, the vision was about 1 line better at week 24 compared to sham in the ONL-1204 200 microgram arm. Looking further at MAC-off detachment duration, there was about a 2-line difference when patients had a MAC-off status greater than 8 days. Looking further at this by both lens status and duration of detachment, we see a similar trend of about a 2-line difference in both the pseudophakic and phakic subgroups with Mac-off status greater than 8 days. It is important to note that some of these subgroups were relatively small. Overall, ONL-1204 was safe and well tolerated. There was similar rates of redetachment in the treated arms compared to sham when looking at this and considering that it was a small sample size and the differences were not statistically significant. ONL-1204 groups also had a greater proportion of patients with greater than or equal to 8 days of macula-off status. Overall, ONL-1204 was safe and well tolerated with strong efficacy signals with 1 injection at the time of diagnosis and a demonstrated trend towards neuroprotection in patients with greater than 8 days of macula-off status. Further research will look at these patients at highest risk of vision loss. Thank you.
Thank you, Durga. The next talk is going to be subretinal delivery of investigational AbbVie REGENX-314 as a gene therapy for AMD. First-time results in the fellow eye, so bilateral. Arshad Khanani.
Thank you, Dante. I want to thank Barbara, Sophie, and Diana for allowing me to present this data. On behalf of my investigator, I'm very thrilled to present the first-time results of the fellow eye bilateral study with ABBV-RGX-314 in patients with neovascular AMD. As a reminder, this is the first time that we are dosing the fellow eye of gene therapy in patients with neovascular AMD. Here are my disclosures. So before I go into the design and the data, I want to show you why ocular gene therapy is exciting, because it has the potential to close the gap between the randomized control trials and real-world outcomes that we have seen with current standard of care. When you look at the potential of bilateral dosing of gene therapy in neovascular AMD, we know that neovascular AMD is a frequently bilateral disease, and the ability to treat both eyes with gene therapy is important to have good long-term outcomes and decrease treatment burden. We have 2 other subretinal AAV gene therapies in IRD space that have done bilateral dosing, but we know that after exposure to AAV vectors, antibodies are formed which could impact the potential to dose the second eye. When you look at the outcomes of bilateral dosing, they may vary because we have other factors such as route of administrator that can play a role in terms of efficacy and safety. And for subretinal delivery of ABBV-RGX-314, as we know, presence of pre-existing antibodies to AAV8 did not impact the results in terms of safety, protein production, or efficacy outcomes in the first eye. So the goal is to see if we can replicate those outcomes in the fellow eye. ABBV-RGX-314 is designed to treat neovascular AMD. This is an AAV8 vector that takes a gene of an anti-VEGF Fab. We have seen subretinal program, which is more advanced, as well as suprachoroidal program in neovascular AMD, as well as diabetic retinopathy. Looking at the status of current programs, here's the summary of all the programs. The focus today is the fellow eye sub-study of ABBV-RGX-314. We have seen that the subretinal program, as I mentioned, looked at overall safety and efficacy endpoint. We have seen it has been well tolerated across phase 1 and 2A study, as well as a phase 2 study, and we have seen good long-term efficacy and safety data. We have seen stable or improved visual acuity and meaningful reduction in anti-VEGF injection. This is a video of my first injection I ever did over 5 years ago. The current program is in pivotal Atmosphere and Ascent study, and now let's look at what is the potential of bilateral dosing in patients with neovascular AMD. We had 20 patients total treated in their fellow eye. As I said, this is the first ever bilateral gene therapy trial to date in neovascular AMD. And we'll be looking at the 10 patients that were part of the open label study as we analyze the data. These patients were standard of care treated patients. They receive a ranibizumab injection 2 weeks prior to dosing with ABBV-RGX-314. They did not have to show a response like we did with other trials. It's just that it's standard of care, stable patients that needed anti-VEGF injection. And this study is designed to evaluate safety, immune responses, and efficacy of ABBV-RGX-314 in the fellow eye. Looking at the demographics, good visual acuity, stable patients with about 250 microns of OCT. But one thing I want to highlight is the treatment burden. Patients receive almost 8 injections, actual injections, in the prior 12 months. And some of these patients actually receive more durable agents, including faricimab. So when you look at the safety, it's a priority. It was well tolerated in all open label subjects. We did not see any new safety signals. We did not see any drug-related SAEs. No cases of intraocular inflammation, vasculitis, hypotony, or any other events were observed. We did see pigmentary changes like we have seen in the prior studies. Now let's look at the efficacy. Second eye treatment of ABBV-RGX-314 resulted in 78% of treated second eyes that were injection-free through 9 months. And as you see those eyes, they only received 1 injection over 9 months period. So 100% of the treated second eyes required either 0 or 1 supplemental injection post a single subretinal injection of ABBV-RGX-314. Looking at the reduction in anti-VEGF burden, we have a 97% reduction in anti-VEGF burden in these fellow eye patients treated with ABBV-RGX-314. Now, we want to make sure we are not compromising on visual acuity or anatomy by not, treating these patients, and reducing the burden. So when you look at this, we see the maintenance of visual acuity or improvement of visual acuity and maintenance of central retinal thickness in these patients, really highlighting the efficacy. Another parameter, which is an important parameter for gene therapy, is to look at the protein production in the eye after a single injection of ABBV-RGX-314. So here we see the treated first eyes had the levels of around 475 at 6 months from the data you have seen already in phase 2. And here we have similar levels in the fellow eye of the same patients, showing the durability and continuous protein production and sustained delivery of anti-VEGF with ABBV-RGX-314. Here's a case from my friend Stephen Huddleston. You can see this patient had fluid at baseline and received 9 injections in the first eye and 7 injections in the fellow eye, and has been injection-free with improvement in visual acuity after a single treatment with ABBV-RGX-314. In conclusion, second eyes treated with ABBV-RGX-314 achieved similar safety and efficacy outcomes to the first eyes treated with ABBV-RGX-314. I think this is a milestone for the field by treating the second eye for a common disease with a gene therapy. It was well tolerated. We had sustained vision and anatomy, similar protein production. 78% of patients were injection-free. 100% of patients required 0 or 1 injection, and 97% reduction in anti-VEGF treatment burden. I want to thank all the investigators and REGENXBIO team for participating and helping with this study. Thank you.
Okay, panel, let's go ahead and discuss these 2 talks. Let's start with Szilard. Szilard, let's start with ONL 1204. Seems to have missed its primary endpoint here in this earlier phase trial. How would you go forward, or would you go forward with this for this indication?
I want to congratulate the team for going after something that we all see in our practice. We can anatomically fix the retina, but the patient oftentimes is not happy. And so would I go forward? Absolutely. The timing of the injection, looking beyond just the macula on and macula off status, looking at the outer retina, and then also multiple injections per se. It's hard to be a trailblazer, and David Zaks and the team at ONL are trailblazers. So it's awesome to see that they're going after this condition. They just have to work out the details, as I said.
Richard, any way you might give them some free consulting advice here from you without pay? How might they enrich their population?
Well, I think one of the issues is we know that 8 days is still a relatively short period of time, and fixing these kinds of detachments within a week, that a lot of these patients do well. So it's hard to improve good to great. So I think there's going to be a tremendous role for this technology in patients who have longer duration macula-off detachments, and certainly possibility of dosing more than once would make sense. But I'm tremendously excited by this technology because I certainly have seen patients who, for one reason or another, can't have surgery in the first couple of weeks. And sometimes they do amazing, but most often they do less than stellar.
Alan, anything to add before we move on to the final?
Yeah, I think I would agree with applauding a new pathway and the work that David Zaks and colleagues have done. You know, people will often say, why did you pick retinal detachment first? Well, that was the preclinical model that they could activate the cell death pathway. So I'm optimistic about the pathway regarding retinal detachment. I'm not sure, but the encouraging early data sets from glaucoma and geographic atrophy definitely make me want to pursue this program.
Yeah. Dimitri, let's move on to talk 4, Arshad's talk, Regenex in the fellow eye. What do you think? That looked pretty good, didn't it?
It's definitely fascinating to see that we are here even talking about bilateral gene therapy for neovascular AMD. Yes, the exciting idea that we may have to relieve treatment burden for our patients. I just like long-term data and what the preclinical data have shown us. And there is we don't know what the long-term effects of continuous suppression of VEGF is in the retina. So the only caveat I have, what happens in 10 years, and we have something we cannot stop. So it's great, but I think we need to be cautious with the long-term data and make sure we don't miss a signal, especially in patients that we've done it in both eyes.
Szilárd, this was subretinal gene therapy and seemed to really do well as far as efficacy and safety. Do you think there might be a difference in using a fellow eye treatment with an intravitreal approach, for instance?
You know, I don't think so. I think that we have some preclinical data that's coming out in non-human primates. You know, it's awesome because we're talking about potentially in a significant portion of patients, whether it's subretinal or intravitreal, really using the C word, which is a cure, right, for wet AMD. And, you know, talking about 50, 60, 70% that don't need another injection. You know, the challenge with subretinal is a surgery, although we love doing surgery. So, you know, but I think it's great for the field. We can do both eyes. It's a bilateral disease. So congratulations.
Richard, Regenex is in their phase 3 clinical trials. If they turn out positive with a fairly good safety signal, are you going to be using this in your patients, and which patient?
I think there are definitely patients who would go for the surgery for one and done that basically. I do share some concerns. The question is certainly the data that Barb showed yesterday was something to think about in terms of long-term anti-VEGF suppression and the possibility, so we got into a situation where we can't reverse it. But, you know, I certainly know that there are a lot of patients that would benefit from this. So I would, you know, I'd be very selective, but, you know, patients will sort of decide whether they think that this is a good choice for them.
Alan, I'll give you the last word on this. You've been involved in this project for a long time.
I love the science. I think injections are not going away as first-line therapy for wet AMD. But I'm interested in burden of treatment. I enjoy seeing my patients, but I'm more interested in vision over time. So the pharmacokinetics, instead of having pulsatile levels and making our real-world observations of vision going like this in years 2, 3, 4, 5, 6, 7, et cetera. I'm interested, and we're seeing this a little bit from PDS and some of the gene therapy programs, that vision is holding for longer. So that's what I'm really interested in.
Well, I'd like to thank all the speakers and, of course, my perfect panel here. Their insights are very valuable, and it's an exciting time. And there are lots of late breakers that were submitted, and so there's a lot going on in our field. Thank you. Thank all. Good job, guys.